Today I want to start by giving a presentation that kind of pulls together a lot of the approach that we use in clinic to understand and treat the patients that we see, and also tries to give some context to a lot of the questions that we get asked in the hallway and that we get asked pretty frequently by families who come to conferences and who come to our clinic. I think I was very struck a couple clinics in trying to put myself in your shoes and come to a conference. I was very struck at a couple conferences when I was trying to put myself in a parent's shoes and see the list of presentations and all that kind of lingo and words and risks and all these things that professionals are kind of throwing out there. And we have very good backgrounds as professionals in all these terms because we've been in school for a really long time, but that is not necessarily your areas of expertise. And so I felt like we need to do some things to kind of help kind of tie it all together in understanding how the risks relate to how the different conditions can be so variable and show up in so many different ways. So this is the first time I've done this, and one of the other awards I should get for this talk specifically is the award on procrastination, because I did it, let's say in theory it was in my head for a long time, but doing the slides and putting it all together was late last night. And then this morning when I came to open it up, there was the version that was not the final version, and then the computer froze, and then I couldn't even open anything, and then, so there might be some mistakes in here. Because I couldn't fix it all this morning. Okay, so, but our plan is, my plan is that I really want to describe a little bit about the different neurodevelopmental and medical risks in X and Y variations, and discuss some of the genetic factors and other environmental factors that might contribute to the variability between individuals. I want to talk to you a little bit about our clinical approach, and then have some case examples, and that is one of the things that's not on here, but hopefully I can remember a lot of cases that we can talk about, so that's not such a loss. So first of all, just before we kind of get started, I think it's important to just think a little bit about the definition of, or just talk about kind of some of the definitions. So we have, when you come to a conference, you hear all these things that your child might be at risk for. And for those of you who had a prenatal diagnosis or an early diagnosis, or really anywhere along the way, people will tell you, oh, well, he's at risk for this, he's at risk for this, he's at risk for this. And they listed all these things. And if you look at the entire list, it sounds really scary or intimidating, and they say, well, but you're not, people would reassure you, well, not everybody has everything, and it's really hard to predict, which ones they're going to have, and so you're just going to have to watch and monitor. And I think that would be quite overwhelming to think about that. And so, I get a lot of questions about this from families, and basically we consider something to be a risk associated with the genetic disorder, and in this case, the X and Y variations, when they occur at higher rates than we see in the general population. And so if, something occurs, the risk of ADHD in the general population, some people will estimate as, 10% of kids have ADHD. Well, if we saw 10% of kids with X and Y variations have ADHD, we would say, well, I don't know if it's associated because it's the same as we see, usually. But when we see 50% of patients with X and Y variations have ADHD, then we say, well, it's definitely more common and probably associated with the genetic disorder. So, and you can do that with any of the features that we list, from any of the neurodevelopmental diagnoses to the majority of the medical ones as well. So, if you want to put all of those into a list, in terms of the developmental and psychological risks, you get this really long, overwhelming list that people have talked about. Motor delays, learning disabilities, reading disabilities, ADHD, dyspraxia, sensory, autism. And, a lot of people in different talks have talked a lot about these different risks. When you look from a medical standpoint, there are, all of the X and Y variations have kind of a list of medical features that we commonly see that are pretty consistent between the different X and Y variations. And those include things like low muscle tone or flat feet, seizure disorders, obstructive sleep apnea. Velopharyngeal insufficiency is something we're seeing a lot more frequently. For those of you who don't know what that is, it's a dysfunction in the way the palate kind of closes towards the back of the throat. And so what it does is it leads to kind of some hypernasal voice and some difficulties with articulation of speech, because you need your palate to close and function properly to produce normal speech sounds. And we, in our clinic, had seen a lot of patients who at the beginning, were receiving speech therapy when they were 2, 3, 4 for articulation difficulties. And, but as they got older, despite some good therapy, really their intelligibility wasn't improving. And, at 9 and 10 and 11 years old, we expect with most good speech language interventions that those articulation problems should mostly be able to be treated. And they just, and these kids weren't treated very well. And we, why is he still, sound hypernasal, and it's hard to understand him. And so when we actually did more assessment, and this is on multiple cases now, we find that they actually have, dysfunction of the palate, and sometimes that needs to be treated surgically, and not always. Sometimes there's very specific speech-language interventions that can help it, but it's just very important to know about it if you have it. And we've seen this now across all the different variations. So, but other medical risks include hypothyroidism, constipation, intention tremor that we see, asthma and respiratory infections. Again, while they're very common in the general population and also can run in families, we definitely see them to be much more frequent and more severe than we usually see in typical kids. There's some specific ones for XXY, right? The testosterone deficiency doesn't occur in trisomy X and doesn't classically occur in XYY, although there's been a few cases that have been reported. And, the decreased bone density or osteoporosis, type 2 diabetes risks, and blood clots and DVTs, those have been reported as increased risks in XXY, but not in the other ones. And then in the girls with trisomy X, we've seen increased rates of hip dysplasia, renal abnormalities, congenital heart malformations, premature ovarian failure. So there's some that are unique to each condition, and then some that are across the board. But again, not everybody with XXY or everybody with, a specific X and Y variation has all of these things. So what determines which risks may be present in each individual? And the way that I usually kind of frame that for families is that when you have an X and Y chromosome variation, you have overexpression of genes from that extra chromosome. And we know that that leads to differences in the way the brain develops and in differences in the way, other organ systems function in some cases. And so it makes the brain for sure, and then other kind of medical pieces as well, more vulnerable to other factors. And then when other factors act and come in and act on that kind of vulnerable brain, or that that brain that has been, developed in just a little bit of a different way, it can lead to then those clinical features. And so kind of the way I like to describe it is that, there's kind of a threshold for when you're going to, have enough biological difficulty that you're going to see ADHD, or, a threshold for every kind of risk factor. And then once it get the factors driving that reach above that threshold, you're going to display the feature. And, I think at baseline, some of the features and the risks that we talk about are all at different kind of levels from that threshold. So, the only one I could really think of, and I'd love if someone could give me some other examples, but there's, the only one that I see always very consistently, and that we know, with the exception of probably some very few cases, but in boys with XXY, the small testicles and testicular failure occurs, in adolescence in, 99% of cases. And that's the only one that I know definitely is above the threshold for everybody with the condition when they're born. It doesn't show up when they're born. You see it occur in adolescence. It doesn't mean, some guys with XXY, they have smaller testicles. They still produce, fairly sufficient levels of testosterone that they don't necessarily have to be on testosterone replacement. But still, the infertility piece is still there in those males. So that, that's the one that's universal. All the other ones, the facial features, even the tall stature, the neurodevelopmental pieces, they're not universal, and they're, likely at different distances from that threshold. And so, we see learning disabilities very frequently, and so since those features that we see more commonly are likely closer to that threshold than the ones that are less common. There are documented increased risks for schizophrenia and bipolar disorder in XXY, in trisomy X, in XYY, but they're definitely not as frequent as we see speech delays and learning delays. And so for bipolar disorder, it's likely that there's other factors also that just need to be kind of additive to get you above that threshold. So, risk factors and other kind of things can contribute to then push things up towards the threshold before someone will manifest one of the associated diagnoses. And I wanted to spend a little bit of time just talking about some of those factors and what we do know in terms of background research, specifically in the X and Y variations, that might contribute to that. And there's some of our research in here too that is not yet published, but will gives examples of some of these. So some of the ideas are that, there's differences in the genetics of the X and Y chromosomes themselves. I mean, we know there's an extra X or an extra Y, and so, and that they're being overexpressed. But in one individual, if it's being overexpressed a lot, and the other individual, it's only being overexpressed a little bit, well, then this individual is probably more likely. So it's overexpressed in, both of them as part of the having an extra X or Y chromosome, but this one is the one who's going to end up having the feature. There's also something called polymorphisms, and that means that there's kind of variations in a gene. And so between different people, there's different kind of coding sequences of the gene, and it leads to the same gene product or the same protein, but those proteins are formulated just a little bit differently. And so if you have one that's kind of shaped, and a good example of this is kind of receptors that are on, our nerve cells. And so the neurotransmitters in the brain, all the brain chemicals act, and then they go bind to the receptor, and then it stimulates, the next step in terms of signaling. And so if, you have one receptor that's kind of shaped this way and the other receptor that's shaped this way, they might be two different polymorphisms. And this one, when the chemical binds, might react really strongly and send a really strong signal. And this one it still works, it just doesn't send a signal that's quite as strong. And so if you have, this form of the receptor, you might have a different clinical picture. Things might work just a little bit differently than if you have this form, even though, they're still pretty much the same. So they're called polymorphisms, and there's just different variations of genes, but they still code for the same thing. So those would be things that are kind of inherent in the genes that we see overexpressed on the X and Y chromosome. Other genetic factors could also play a role, right? We have 22 other sets of chromosomes. A lot of times we leave all those extra copies out when we're drawing the diagrams of where the X's and Y's go, but you have to remember there's 22 other sets of chromosomes there too, and there's a lot of genes on all of those chromosomes that might contribute as well. And so there's some polymorphisms on some of those genes that, or some of those chromosomes that we know might contribute to risk factors. And then there's also, a lot of traits that we know run in families, looking at big studies, but we don't necessarily know the specific gene that leads to those increased risks. So we know, family histories of anxiety, and anxiety disorders can run in families. We know ADHD can run in families. We know reading disorders can run in families. And while for each of those there are some genes that are identified, we can't explain the entire heritability and increased risk of those different conditions. And so, we commonly ask a lot of questions about, well, what else runs in your family? And a lot of questions we get are, I have problems with ADHD in my family? Do you think that, he just has ADHD because of that and not because of XXY? Or we get, I have a lot of difficulties with anxiety myself. I need to be tested for XXX because I have, anxiety too. And then I think I must have XXX also, but it's really just, more of a generalized anxiety. When we check the moms, we reassure them they don't have trisomy X also. So, there's a lot of those things that, just general family genes that definitely could be a second hit there also, right? And contribute. Other medical problems can definitely also act on neurodevelopment as well. So if you have kind of a vulnerable brain and then you have prematurity, or you have meningitis, or you have some other exposure to prenatal exposure to alcohol, well, you have a vulnerable system already. You add a second problem, you're going to have more difficulties. And then, when we take out the genetics, then we always think about the environment. And, some people interpret it literally, like environmental exposures to chemicals and pesticides and those other things, which, maybe do affect neurodevelopment. But in general, we also think about environment as, the house you grow up in, the environment and learning opportunities and family supports and all those things that you have around you that also shape who we become and how we learn and other things. So those factors may also play a role as well. So, what do we know and what evidence do we have of any of these in the different X and Y variations? We do have some, preliminary information. There's not, so overall there isn't a lot of research that has quite correlated genetic factors or environmental factors to, the presence or absence of different conditions that the individuals are at risk for. But we have a few, and so I'm going to point those out here. So one of them is, we do have some evidence of polymorphisms of specific genes on the X chromosome that are likely related in XXY. And one of them is called the androgen receptor gene. And I talked about this a little bit yesterday, and I think some of the endocrinology talks mentioned it too. But so the androgens are testosterone, or male hormones, and so sometimes it's also called the testosterone receptor. But there's many different types of male hormones. And the gene that codes for the for the testosterone receptor is actually on the X chromosome, and it comes in different, what we call polymorphisms, or different variations. And so the variation within this gene is a difference in the number of CAG repeats, or little coding kind of sequences that repeat. And some people have very short CAG repeats, they only have a few of them, and other people have more of them. And depending on the length of your CAG repeat, it changes the receptor formation just a little bit, such that those with a short CAG repeat are more responsive to testosterone. It triggers a stronger signal when the testosterone binds to it. And those with the long CAG repeat codes for a protein that then binds to, when the testosterone binds, it doesn't send quite as strong of a signal. And Andrew Zinn in 2008 published a really important paper where he showed that the length of the CAG repeat was actually correlated with a lot of features of Klinefelter syndrome. And so those with the short repeat had more of a response to testosterone, had kind of fewer symptoms of KS. They were shorter because we know, in more, KS is taller, so they actually had shorter stature. They had less gynecomastia. They had more professional jobs, and there were increased likelihood of being in long-term relationships. So it showed that there were some physical aspects like stature and gynecomastia, but also some kind of psychological or outcomes features as well that might be associated with it. And so that sets the stage for us thinking, well, the testosterone is going to act on everybody, but maybe those individuals who have the long repeater, the less responsive testosterone, are going to be the ones who are kind of more affected in some ways, or in the future with more research, maybe they need higher doses or different types of testosterone or something else. But we first have to really understand all of these studies that I'm showing you are all very small and have not necessarily been replicated, and so there's a lot more research before we're, really getting excited on what aspects of changes in clinical care it leads to. But this is really interesting to me, and I presented yesterday some of our data where we looked at the effect of testosterone on kind of psychological and behavioral features after a group of teenagers and young adults had been started on testosterone and were treated for a year. And what we found was if you took the orange or the red line on here as the whole group together, and again this is a small sample, there were only 16, but if we looked at the red line after a year of treatment, there was no change in negative behaviors or externalizing behaviors, and we saw improvements in attention span noted by parents, and then improvements in kind of personal adjustment, which would include self-esteem and other similar factors like that, noted by the individuals, by the teenagers themselves. And so we said, well, I wonder if, is there any factor within this group? Because some of the kids didn't really seem to improve that much at all, but so these are the averages of the entire group, and other kids really seem to make big changes. And so one of the things we did was look at this CAG polymorphism, and we found that those with the long repeat actually had less changes than those with the short repeat, and so it kind of is consistent with that. Those that maybe have a more sensitive, a more responsive testosterone receptor might be responding to testosterone more and leading to these effects, whereas if you have the short or the long polymorphism, you're not going to have as much of a response. So this is the preliminary data that kind of led to our current study that's placebo-controlled and in a much bigger group, and we're going to continue to look at this. When you have only 10 people in one group and 6 people in the other, it's really hard to draw any conclusions because it is a small sample, but this was really pretty promising. So then, in terms of other genetic factors, so those are things we know are associated with kind of the features of the X and Y variations, but what about other genes, on other chromosomes, or genes that we, don't think are necessarily related? And there's a lot of research in other neurodevelopmental disorders and mental health conditions that's looking specifically for genes associated with those conditions also. And so there is a gene that is called the Mao-a Gene, and it's actually on the X chromosome, but it's X inactivated, and so we don't think there's actually overexpression in most individuals with X and Y variations. And what the job of this gene is it codes for an enzyme that actually breaks down a whole bunch of neurotransmitters in the brain, and some of these neurotransmitters are serotonin and norepinephrine and dopamine, and these are a lot of the neurotransmitters that are involved in anxiety and depression and ADHD, and a lot of our medications that we use to treat psychiatric and emotional disorders and ADHD target these neurotransmitters. And so what happens is that polymorphisms also, or different forms of this gene, affect the efficiency of the transcription of the gene, or how much is expressed. If you have, and the different, in this one is the number of copies of the gene that you have. So the most common is to have either 3 or 4 copies, but some people have 2 copies, and some people have 3.5, and some people have 5. But previous research in other conditions shows that if you have the 3-copy polymorphism, you have kind of lower enzyme activity, and this has been associated in other studies with aggression and impulsivity and conduct disorder. It's been associated with severity of autism in autism studies. And then a 4-copy polymorphism has high enzyme activity, so it works, to break down the neurotransmitters more quickly, and that's been associated with anxiety symptoms and panic disorder. And so, since we have DNA samples on a lot of our patients and a lot of information about their behaviors, we also looked at this in our population. And our study, again, it was small, but it was actually a collaborative study between patients that we've seen, saw starting at the Mind Institute, and then when I came here in 2007, we've continued, and then we also collaborated with a group in Italy who sees Klinefelter syndrome as well. And it's very nice to collaborate with professionals in Italy because you get to do some nice travel. For those students in the audience, when we were talking about some of the benefits, we talked about this last night at dinner, the benefits of research as part of our careers is that you have these collaborations, and now I'm very selective about who I collaborate with, if they live in a cool place or not. Otherwise I have to be doing something really great. But this group included 38 males who had XXY and 17 males with XYY, and there was kind of a pediatric group and an adult group, the majority were still pediatric patients, but we had some that were adults, especially in the XY group. And they were pretty even in terms of, some were prenatal diagnosed, some were postnatal diagnosed. And so this is just kind of to summarize that, but what we did was we had the genotypes, or how many repeats they had of the gene, and then we also had the behavioral questionnaires that were filled out by their parents. And this was in boys with XXY, and the bars divide the three, whether they had 3 and 3 on their 2 X chromosomes, 3 and 4 copies, or 4 and 4, because the boys with XXY have 2 X chromosomes. And basically, and then the BASC is a questionnaire that parents fill out, and it categorizes, the anxiety or aggression or the different behaviors and how severe they are. And on the BASC, a score of 50 is average, and so if you have scores between 50 and 60, it's kind of considered average, and then above 60 is at risk, and it goes up from there. And so in this questionnaire, these are the group averages, and so, the boys with XXY had high levels of anxiety, but the highest levels were in those who had the 3 and 3 repeats, and then we also saw high levels that were statistically significant in terms of withdrawal, which are symptoms that can sometimes be associated with anxiety. And again, the bars that kind of stood out that were statistically different were the ones that had 3 and 3 and 3 and 4. And so, and that statistical difference was actually much more than the anxiety scale itself. So we thought this was interesting, but we wanted to look a little bit more also at the adult sample. And when we looked at the adult sample, the BASC doesn't, you can't give it to adults because it's for children, and so they took another questionnaire that's called the SCL90, and they actually, on the adult samples, there were only 18 in this group, but on the category of what's called phobic anxiety, there was also the same difference in the adult group. And so those with the 3 and 3 and 3 and 4 had statistical differences compared to 4 and 4. So it seems that if you have the 3 repeat polymorphism, it increases your risk for anxiety and demonstrating the anxiety in the population of males who have XXY. And it was kind of further confirmed when we looked at the boys with XYY, again, that those with the 3 copy repeat were statistically higher in withdrawal. It didn't show up here in anxiety. It did show up in social skills, but sometimes, but again, this was a small sample too. There were only 15 in this group. So, this is some preliminary evidence that maybe in XXY and XYY, at least, that these other polymorphisms, the other genes that we know are associated with anxiety and emotional states contribute as well to the background differences that we see from the X and Y variations to kind of get you above that threshold. Now, other family background genes, we know can also contribute, and so there's many that we don't necessarily know the specific one, but we have some. And so there have been a few papers that have been published recently that have supported some kind of other genetic, looking at the risk in the family, it contributes as well. And then there's been a recent paper by Martine Otter that was just published, and it was a very small paper on 2 patients who had trisomy X, but they were 2 girls with trisomy X who had been exposed to physical abuse and sexual abuse while they were growing up, and then went on to develop schizophrenia. And so they're sad cases, but his point when he describes these cases in the paper is that we know that there can be severe mental health issues associated with some of these conditions, and that they do occur more commonly than in the general population, but that if there's a big stressor, such as physical abuse or sexual abuse, then that's going to really push you up to above that threshold. So you already have some risk, and then you're going to have a big stressor that then pushes you above that. And it's the consideration of kind of what the environment is, and if you have a really negative, stressful environment on top of this vulnerable brain, you might be pushing a lot of those mental health risks up a little bit higher. So I think it's a really important paper, and the way he writes and describes the theory of how you can get to these more significant mental health problems is really important to think about. So then, kind of on a brighter note, the other possibilities are that, well, maybe instead of having a second hit or a second risk factor, what about having positive factors that maybe make the risk less likely? And are there protective factors that actually can help prevent difficulties? And so they're actually, the idea would be that these kind of push things down away from the threshold instead of kind of bringing it up. And there isn't, this I think is a really important thing. We always tend to focus on the negative and focus on the risks and focus on all these things, but when we're thinking about treatments, the treatments and the interventions that we develop are going to have to be these things that, help and improve and are kind of protective and lead to improvements. And so, I think this is an area where we need, now that we know all the risks, let's start talking about the positives, right? And the things that can lead to better outcomes, not always the worst outcomes. And so, there aren't a lot of papers published on this, but I think one of the most important papers was actually published by Mary Linden, and the whole group that won one of these awards here, Dr. Linden, Dr. Bender, and Dr. Robinson, who did all of those prospective studies where they followed babies from birth all the way up to adulthood, and they really described a lot of the natural history of the conditions. And they were the first groups. There were many research groups around the world who did it, but they kind of took the lead in describing what happens from birth to adulthood from just in the natural course. And because before that, the only people who had been described were people who were identified because they had very severe intellectual disabilities or behavioral or psychiatric disorders. So they said, we gotta wait. We know this is happening sometimes in this group, but we need to study everybody and all the newborns to see how common the X and Y variations are, and then follow to see what happens. And they really kind of normalized and said, hey, look, these individuals don't all have mental retardation, and they really most of the time don't have mental retardation, but they're at risk for some of these things. So they really changed how a lot of people viewed the genetic disorders, when they were first described back in the 1960s and so. So, but one of the papers that they wrote looked at, kind of just environmental factors, and they, did show that the more stable kind of the home environment, it was very protective, and those individuals ended up having better outcomes in terms of school success and less emotional disorders and less problems compared to those who had more stressful home environments. And I think that, that's an important thing for all of us and as parents and supporters of these patients to think is, we play such a role in providing as best we can a kind of stable and supportive environment. But, and there's some things that are out of your control, but there's always going to be stresses in families and other things. But just thinking about how to kind of keep things stable, and I think one of the things we talk a lot about in clinic is, helping families say, well, we know you're here to treat your child, but, to have and be able to really provide all the supports that you need for your child, it's really important for all of this treatment plan that we're going to give you to rest on a stable home and stable parent. And so a lot of parents, because there's so many stresses of having kids, they don't necessarily take as much time to support their own mental health or their own relationship with their spouse or with their friends, and then that can spiral out of control if problems aren't addressed, and then lead to then they're not even able to provide the supports for their kids. So having different stresses that come with raising a child who has various learning or emotional difficulties, takes a toll on individuals as well. So you guys as parents and supporters need to remember how important that is, and seek some help and support when you need it, or if someone suggests that you might need it, right? So even if you don't think you do. So there's probably a list of a lot of other protective factors that, why I don't need research to necessarily say that likely leads to improved health, right? We know better nutrition, we know exercise, so we could probably sit here and list many other things that are protective from a medical standpoint as well, but just kind of healthy physical behaviors. And then obviously healthy kind of emotional settings as well. And sometimes when you say, well, what's a protective factor versus a risk, well, staying in, positive social relationships would be protective, but that means you're not exposing them to the risk of, bullies and maybe people who are taking advantage of them. So, some things, you could put them in, bullies are a risk, but, no bullies is protective. So something like that. So now that we kind of have this list again, I want to kind of share how I take all these risks when we see a patient and then put them together to, really come up with, how we conceptualize and develop a treatment plan. And so, the way that I usually organize it, and I think you guys are really going to benefit from, remembering this, and so you don't have to write it down because you'll get handouts from the slides and it'll be in there. It's a little complicated, but I really think it's really become a lot more simple to us, and this is the diagram that we use to explain it to parents. And I think we have it now. And actually, this is a joke, and if you guys have seen this before, I used this slide before, but I love this slide because this also conveys what I feel like many parents sometimes feel when we're throwing all these lingos and diagnoses at them, and so many things overlap, and, well, what do you mean that's a symptom of this? How do you know it's not a symptom of that? And, and there's so many different neurodevelopmental things. So this is actually not our model. I'm very much less creative, and you'll be very disappointed, but this is the model that we use when we give feedback. And so basically, this evolved after we started the clinic because we do these feedback sessions where it'd be myself and the psychologist, and we'd be talking about the speech evaluation and the OT evaluation and what the endocrinologist thought and what I thought. And then it got a little overwhelming. So I said, well, we just need kind of something that we can, like a worksheet we can work on, and when we're talking about the results of all the different testing, so parents know, where we are and what we were testing. And we developed kind of this list, or this kind of grid. And for those of you who have been to the clinic, sometimes we're a little better at really writing on it than others, but we try to really show, okay, now this is what we assessed here, and this is where we put things. And so basically all I did was, kind of break things into categories of what we were assessing by different providers, and just put, each of the features that we know kids are at risk for under each thing. And so under, general cognitive abilities, we know there's verbal cognitive deficits, that in, most cases there's not intellectual disability or mental retardation, but we do see higher rates of intellectual disability than we do in the general population. Under academic disorders, we can see reading disabilities, which is also called dyslexia, or other more general learning disabilities. We can see, many different speech and language disorders. We can see executive functioning and attention disorders. So you can see how in each of these categories, I basically just plug them all in. And then, under there too, it's also important just to have the medical considerations, because sometimes when we see patients in clinic, we say, well, this patient is having attention deficits, for example, and, having a hard time in school and really seems to be distracted. But, part of our medical history also included, well, she, has a hard time falling asleep, but when she's asleep, she, snores and is really restless and wakes up, and she seems to be gasping, and then in the day she falls asleep and she's very tired, and, it sounds like, well, there's definitely some concerns there for sleep apnea, And if there are problems breathing or obstructions in the airway during sleep, you stop breathing, you wake up, you don't get good restful sleep, and then that can contribute to daytime sleepiness and attention problems and other things. And so if I was just looking at concerns about daytime attention and not thinking about the medical pieces, we might say, well, it really sounds kind of like, I don't know why she's tired, but, it sounds like ADHD. We know ADHD can be associated with trisomy X. But if, then you want to make sure you're doing enough of a workup to evaluate for sleep apnea, because maybe that needs to be treated first, and then we can reassess whether or not there's still attentional problems after that, and after you can get the sleep issues corrected. So that's really true and kind of the primary thing for almost all of the neurodevelopmental disorders, and really, one of my big roles in the clinic is, okay, are we missing anything from a medical perspective that can contribute to neurodevelopmental problems, because that's going to be important to treat. So this is the approach that we use, and I wanted to kind of give an example of a case, or some cases, to kind of show how it all works and how it all fits together. And this is where we're going to have poor slides, but you're just going to have to listen to me talk, and I might be a little scattered. So this I was just, when I was up here typing, this is kind of what I recall. So an 8-year-old girl with trisomy X came to clinic, and she had a history of speech and motor delays. She was diagnosed with trisomy X when she was 3 due to developmental delays. She wasn't making progress, and so the pediatrician said, well, the mom said, are you sure what is going on here? Are you sure there's nothing else that's going on? And the pediatrician said, no, she's just slow, and we're treating her with speech therapy, and don't worry, she'll catch up, and, but if you really just want to be sure, yes, I'll send that testing that you asked for. And so the pediatrician sends the genetic testing, and oh my, I've never had a case of this before, but she actually has trisomy X. And so let me just refer you to someone who knows what that is and what we need to do next. No, I should not. Well, that is a very common story, unfortunately. So she received early therapies. She had an IEP at school. And so the diagnosis helped her from that perspective. And they understood what she had. They read about it. They knew she needed an IEP. They put her in the school. And then in first grade, she was having attention problems. And, the teacher said, well, she's just not paying attention in class. I think she might have ADHD. And we were reading this thing. And, it sounds like girls with trisomy X can have ADHD. And we filled out these, questionnaires. And maybe you should go talk to your doctor about it. And then she was started on ADHD medication for that. And, her parents saw maybe some improvements, but it wasn't clear. And now in second grade, she's having a lot more problems. She has an IEP, and they know she has a hard time learning. And so they give her extended time when they do testing or assignments. And, sometimes when they have, little worksheets or little tests, they kind of read the questions to her and give her some extra support instead of expecting her to kind of really try and decode it or read it on her own. They have some ADHD supports where she's sitting in the front of the classroom. But at school, she's having lots of outbursts. She is, becoming resistant to everything. She doesn't want to do it. She cries. She hides under the table. She runs out. She's withdrawing. She just doesn't really want to participate. And she can get some stuff, but then, she gets overwhelmed. And so, they're asking, well, does she need more ADHD medication, or what should we be doing here? So when we did our assessment, what we found was, and she had an assessment. She had an assessment by speech and language therapy. So she had an assessment by our psychologist. She had an assessment by our OT, and then by myself as well. And basically, when we did the testing, her IQ came back in the intellectual disability range. And it was, in the high 60s, but it was definitely much lower, and she'd never actually had cognitive testing before, or IQ testing. She'd had some developmental, speech and language evals and other things, but, she did have speech and language delays that were pretty significant, and she had been receiving speech and language therapy, and this kind of speech and language disorder, continued, but a lot of her speech and language scores were actually fairly similar to her cognitive abilities. I mean, if someone has intellectual disability, you don't expect them, you expect their speech to be at least at that level. She was a little bit lower than that, and there was, felt that there could be some work that could be done to continue to support her language development, but, but it wasn't her primary difficulty. And if you only did speech and language testing without the understanding of where her IQ was and where her cognitive testing was, you just think, oh, let's throw more speech at her because she just needs speech therapy, speech therapy, speech therapy. But it wasn't quite, that simple. We really didn't see any difficulties with attention, and had her come back without her medications one day just to make sure that they weren't just like a perfect response to medications, and even off of medications. She looked really good, and no one really had attentional concerns. I mean, when things got hard, she started to look around, but all of us do that, right? Some of you are doing that now. And so, you when you're bored, you just kind of, and so, our interpretation of that was, she's sitting in the classroom, and she was pretty much mainstream with some pullouts for speech, and she wasn't, so if everyone is around her is expecting her to do all this stuff that's way too hard for her, you're going to become inattentive. You're going to look inattentive, right? And so we really felt like, there were some, ways she could learn to kind of problem solve or start to strategize, but we didn't feel she had ADHD. We did see some anxiety, and, again, this is hard. Did the anxiety start first, or does the anxiety start after being kind of in this stressful setting where, she's been kind of thought to be functioning at a much higher level than she actually was and understanding more than she was. So you take the cognitive piece, and then some, anxiety is going to come from that. But there was, definitely some anxiety. And then the emotional pieces we felt really were related to frustration and anxiety at these expectations that were probably a little bit too high for her at that time. She also had auditory sensitivities and tactile sensitivities, and so, those can also contribute very frequently to looking inattentive. If you hear a noise and it kind of freaks you out, or you're distracted by it, and then you hear something over there, and then your clothes is not comfortable, you're going to be fidgeting, and so, kids who have sensory processing problems or heightened awareness to their environment can also look a lot like they have ADHD unless you're doing more questioning and understanding of what the sensory contribution might be. And so our occupational therapist was able to really identify that, I think this is really affecting her in a lot of different ways. We, in this case, also felt, I order a lot of sleep studies because, again, I know we all know how important sleep is, and there is a risk for sleep apnea in these conditions related. I don't know 100% why that risk is, but I think some of it is related to the low tone as well. And so she had some sleep difficulties and restless sleep, and so I felt like it was important to evaluate for a sleep disorder. And then she also had some motor delays and low muscle tone, and her adaptive functioning was overall, in the disability range as well. Adaptive functioning, for those of you who don't know that term, is kind of how they're functioning in day-to-day life. Do they, get dressed on their own? Do they brush their teeth? What's their toileting skills? What are their communication skills in, regular environments? Can they use the phone? Can they, send an email to someone? So there's different levels of adaptive functioning we expect along the lifespan. And usually your adaptive functioning types of scores are similar to your IQ scores in most cases. So you function kind of at the level of your cognitive abilities. Sometimes there are people who function much higher, than your IQ is. And some of us, I'm sure many of us know those people who seem to be really brilliant and book smart, and then, you can't figure out why they can't kind of get their lives together, and they have much poorer adaptive functioning. And so our feeling is that, and we often see in the X and Y variations, and many of you parents describe this too, well, I know his IQ is normal, they tested it, it's okay, but why can't he figure out how to bring his binder home? you know, and so, or why can't he, you know, figure out, you know, there's just all these people, why can't he brush his teeth, or why does she do this? And so adaptive functioning, you know, to us is kind of, well, you start out with this IQ and then you get all these other factors, the executive functioning, the emotional stuff, the speech stuff, and then it kind of brings it down so that, you know, all of these things, motor skills can contribute to being able to kind of have poor overall daily living skills. So that's what adaptive functioning is. And I think it's really important because it's really kind of how you're actually functioning. And IQ is a little bit false sometimes, right? So, so for her, our plan was really, you know, she needs a more supportive educational environment. I mean, that's the primary issue for her because she's in a classroom setting and she's not receiving instruction at a level that's appropriate for someone with a disability. If you're reading, you know, giving extended time on a test that you can't do, it doesn't matter how much time you have. You know, it's nice that that's on the IB. You're still never going to be able to do it, right? So the support she was receiving through her IEP were not appropriate for her cognitive level. You know, sitting in the front of a classroom if someone goes blah, 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 it doesn't matter if you're sitting in the front or the back or, you know, if you're in the other room, you're not going to be really getting any instruction from that. And so, you know, we really try to make sure that the supports that the kids are receiving are appropriate for where they are in terms of their learning and cognition. I actually, people laugh, I don't usually discontinue ADHD treatments. I'm usually the one who's like, yeah, you guys, come on, we need to start medications. But this was one of the few cases where I said, you know, let's just take her off. I do not think she needs that, and see how she does when we, you know, do some sensory OT strategies. We get her in a better classroom setting. You know, we make sure the medical pieces are taken care of. You know, we continue giving her some strategies in terms of communication so she can get her needs met. And so, you know, when we put all these other things in place, let's see what her attention looks like then. And if it seems like, you know, she still has, you know, something that where ADHD medications might help, but, you know, I just recommended they take that out of the equation. They also can contribute to sleep problems, right? So, you know, this kid was not sleeping well, and so I just felt like in one of these cases, this was an exception for me usually, but, and I think the start was kind of start some of these other therapies and planning and other things. So that's kind of an example of, you know, how we take all the pieces and put it into our, you know, into our grid and really incorporate all of it. And I think many of you, when you're talking with us, you know that, well, I don't know if it's from this or that, or help me understand how to help when there's so many things that can contribute. And sometimes they're fairly straightforward answers, and other times it's still always going to be complex. But I think having an understanding of at least what is, you know, where everyone is in these areas at least gives us something, you know, to work forward from, as opposed to just not understanding where things come from. So I hope that that kind of gives you an idea of kind of how we think about all these risks and some of the background of what we know about the risks, and then also, you know, how to apply it and think about it for your kids as well.